This was a randomized trial that we have conducted together with colleagues in Norway, Sweden, and Denmark. And the purpose was to test the feasibility and tolerability, and of course also the efficacy of increasing the dose of the thoracic radiotherapy. We know that some patients are cured after chemoradiotherapy, but that's only approximately 25 to 30% of patients. So there's clearly a need for better treatment. And since there haven't been any real progress when it comes to systemic therapy for these patients, we wanted to test if increasing the radiotherapy dose might increase the outcomes. We also know that in quite many cases, local relapses are the main cause of treatment failure and is also strongly linked to inferior survival. And we hypothesized that if we increase the thoracic radiotherapy dose, we could increase the local control and then also improve survival. So this study was conducted between 2014 and 2018. We have just reached the time point for the primary endpoint, which is 2-year survival. But we will continue following these patients until all patients have been followed for at least 5 years. And that will happen in 2023. So these are just the primary analysis. I think what surprised us was that it was well tolerated, the high dose radiotherapy. We do not see any differences in radiotoxicity, and the frequency of esophagitis and pneumonitis is lower than in a previous trial that we have performed, and also lower than in previous trials, and in line with what was observed in the CONVERT trial that I guess many of you are familiar with. We also saw that in almost all cases it was possible to deliver the high dose. There were some patients that received a lower dose than they were randomly allocated to receive. We are in the process of looking into those radiotherapy plans, and will also do an evaluation of whether it truly wasn't possible to deliver the high dose. This was a randomized phase 2 trial. So the aim was actually to see if there was any signal of improved efficacy. So we estimated that enrolling 150 patients in total would give us a good signal. The sample size calculation is based on demonstrating a 25% improvement in 2-year survival from 53% that we observed in a previous trial to 66%. And this is with an alpha of 10%. So this is clearly a hypothesis generating trial. But to our surprise, we did find a highly significant difference in favor of the high dose arm for the primary endpoint 2-year survival. And that increased with more than 50% from 46% to 70%. The overall survival data are not mature yet, but so far we also find a highly significant difference for the median overall survival, which is 23 months in the standard arm, and appears to be close to 42% in the high dose arm. We have reached the median survival in the standard arm, but not yet in the high dose arm, so that estimation of median overall survival time can change slightly. So what we presented were the primary analysis of the 160 patients that completed the thoracic radiotherapy as planned. And we are currently also running the intention to treat analysis, and so far it seems that the difference is even bigger in the ITT population than in the per protocol population. So we are quite intrigued, and I have to admit also surprised with the big difference in survival. There was no statistically significant difference in progression-free survival, but also these data are immature, and we are looking into these data to try to see if there's a difference in relapse pattern. One can imagine that relapses occur maybe outside the radiotherapy fields in the high-dose arm to a larger extent than on the control arm. And maybe that can explain why there was no statistically significant difference in PFS. But as I said, we are looking into these data, and they are still not mature. But of course, we plan to do our final report in 2023. So how do you interpret these data? It is a randomized phase 2 trial. On the other hand, not many trials have been conducted in this area for quite a long time. I think that at least the twice daily 60 gray schedule should be an attractive option. It takes 1 week longer, but it's still much shorter than the high-dose arm in the CONVERT trial. There's not more toxicity, and even if the survival benefit is a bit overestimated, which can occur in a medium-sized trial, I believe it's still an attractive option. Now we are conducting another trial. That is a trial where all patients receive chemoradiotherapy, and the TRT schedule is 45 gray. And then they are randomized to receive 1 year of immunotherapy, atezolizumab, or observation. We will have a meeting in Norwegian Lung Cancer Study Group tomorrow and discuss whether we should change the guidelines. I have also called for an investigator meeting. I suggest that we amend the protocol and allow the 60 gray TRT schedule. I think what we need to see now is how this will be received when we publish the results. We are really busy now trying to finish the manuscript and hope to submit it this month. So we will have to look at the reactions. I will also discuss with the colleagues internationally to see, to hear their opinion. I think it's a bit difficult to predict. It is a bit difficult for me to understand why the twice daily schedule of 45 gray has not been implemented universally. We know from many population-based studies that one fraction per day is still widely used in many countries. I understand it's inconvenient, but as has been said many times, if the survival efficacy of a drug had been comparable to the apparent survival difference of the twice daily schedule, many people have claimed that it would be more widely implemented. So that is one question that remains to be answered. But of course, we plan or hope to finish our ongoing trial next year. So I will now start contacting colleagues internationally and see if there's any interest in doing a confirmatory phase 3 trial. I'm not sure if that's possible. I agree that in principle it should be done, but until it has been done or until we start a confirmatory trial, I would at least say that the high-dose schedule here is an attractive alternative. I mean, if anybody is interested in joining a confirmatory phase 3 trial, I would be happy to hear from you. To conclude, we found that administering twice daily high-dose thoracic radiotherapy is feasible in almost all patients. It appears to be well tolerated, and it provides a significant and clinically highly relevant survival difference.